Hello, everybody, and welcome to our special seminar on infection in megaprosthesis. I'm very happy that again so many people joined our seminar, and I'm sure we will not disappoint you because again we have a very good faculty today to discuss the most complex cases involving megaprosthesis. So today we will speak about the rational background for all 3 points: the prevention, the diagnosis, and the treatment of such infections. And we have here Dr. Volker Alt from Regensburg in Germany, Dr. Fabrice Fiorenza from France, Professor Lee Gies from Birmingham, UK, and from the PRO-IMPLANT Foundation and Charité, myself. In the first part, we will speak about the rational diagnostic and treatment approaches, including prevention, and we will follow then in the second part in tips and tricks and some additional topics, including local antibiotic delivery systems and problematic pathogens. As previous special seminars, you can put your questions and comments in the chat, and we will discuss it during this 2-hour seminar. We will speak a lot also about the pocket guides, which if you don't have it yet, you can download them for free through this website, www.pro-implant.org. And we have now in preparation the 9th pocket guide involving the infection in the maxillofacial surgery as well. So with this, I am now happy to start with the first talk involving the diagnostic approach. And I will focus on the facts and the myths. And let me start with a table which Volker Alt will elaborate in his talk later, and that is definition criteria. As you know, there are many different definition criteria, but a very simple one is if we have the leukocyte count in the synovial fluid, as you can see here, there is a suggested cutoff of 2,000 leukocytes or 70% granulocytes, to include also the low-grade infections. And then we have also the microbiology, including sonication. And I will go through these points, how we can have a rational approach for an accurate diagnosis of periprosthetic joint infection. We have here several situations, but only these are confirmed infections. Others looks like infections, but they are not. This is, for example, an allergy, and this is an immunologic phenomenon. And others don't look like infection, but they are infected. Therefore, we are looking for the pathogen which are causing this infection. And the first thing what we can see already is that the majority are low virulent microorganisms coming from the skin. And then we have high virulent pathogens following, such as Staph aureus, Enterococci, Streptococci, and in complex cases also gram-negative bacteria and fungi, which are then most complex situations. And as mentioned, most of them are coming from the skin of the patient, himself or herself, and therefore a decolonization of the skin, meaning that we wash the patient with an antiseptic soap, can reduce every second postoperative infection. But in this talk, we will focus how to diagnose it, and therefore we have different preoperative and intraoperative tests. From the preoperative tests, the joint aspiration is the central investigation because it can tell us within hours, with a high sensitivity and specificity, if this is an infection or not. Of course, we do laboratory tests, imaging, and clinical examination, but the most important is the joint aspiration. And if we want to show how is the rational approach, we will divide the infection in acute, those occurring early after surgery or hematogenous late, and the chronic ones, which occur typically between 3 months and 3 years after implantation. So these two acute and chronic situations we will now go through separately. So acute infections, the first is a wound which is not dry after surgery, or if the patient has an uneventful period and then suddenly has fever and local signs, this is a highly suspected acute, but probably hematogenous late infections. And in both situations, we do not puncture the joint because there are other reasons to or other criteria to diagnose this infection. So local situation or fever, we take blood cultures, but septic revision with intraoperative cultures and change of the mobile parts is also the best diagnostic procedure. The late hematogenous infections, of course, we look also for the primary focus by blood cultures and by looking for other primary site of infections to exclude the primary source of infection. More difficult is to diagnose the chronic infections. Not so if we have a sinus tract, because then the infection is confirmed, but more complex is if we have not a sinus tract, but we have only a painful joint or a loose prosthesis. In this case, we call it invisible infection. And then the central point, as mentioned, is the joint aspiration with determination of the culture, so microbiology, and leukocyte count. Therefore, the easiest way is to have a puncture kit, which includes all the necessary vials and the blood culture bottles in this priority. To first count the leukocyte count. For this, we need an EDTA vial so that the blood is not clotted. And the best for the culture is definitely a blood culture bottle so that we inoculate the synovial fluid directly into culture media and the bacteria can start growing. If the sedimentation rate and the CRP are normal, but the patient has pain or a loose prosthesis, then we should not say that this is unlikely an infection. This is a mistake or a misleading algorithm, because if we have a loosening within the first years or a painful prosthesis in the first years after the implantation, we need to do the aspiration and then detect or determine the leukocyte count. As mentioned, with this cutoff, we have an over 90% sensitivity and over 95% susceptibility. There are only rare situations where leukocyte count is either false high, this is in the early period, therefore in the first 6 weeks we do not puncture the joint, or in some rare situations such as rheumatic diseases or trauma. In case of sinus tract, the leukocyte count can be false low, so we don't detect it neither. Some biomarkers are on the market which can be used in the synovial fluid, such as alpha-defensin, leukocyte esterase, calprotectin, and D-lactate. But until now, we can say that the leukocyte count is still the best routine test, because when we compare it with the commercial Synovasor, the alpha-defensin test, we can see that especially in chronic infection, the sensitivity is very low. It's only 44% compared to the leukocyte count, which is double as much sensitive. The specificity is 99% of this test. So if the test is positive, we can confirm the infection, but we cannot use it as a screening test because of the low sensitivity. The lactate, especially the D-lactate, is in contrast to all other biomarkers, a biomarker which is a product of bacteria, and therefore it's has a high sensitivity and specificity. In one study published last year, it was 98% sensitive, and therefore we hope that we will have soon a test which will be in the routine diagnostic and can give us a result with an electrochemical sensor within minutes, and this will help us much in the preoperative diagnosis. If, however, the leukocyte count is normal, then we need to look for other reasons which are unrelated to infection, such as dislocation, wear, metallosis, or fracture. And if we have no synovial fluid, then we can repeat the diagnostic aspiration after 3 months if the patient has a persistent suspicion, or if the pain is very strong, then we can consider also arthroscopy or open biopsy. The important is that we always think on infection, even that CRP is normal, sedimentation rate is normal, but patient has pain or loosening within a couple of years after implantation. But the main diagnostic tests are intraoperative tests, which are also the most sensitive. In addition to the periprosthetic tissue, we do also histology on this tissue and sonication. The tissue is important not to take swabs, but really tissue samples, not 1 or 2, but better 3, 4, or 5, and incubate them for 14 days to detect also the slow-growing pathogens, for which we need to have at least 2 positive specimens in order to call them pathogens. Otherwise, they are contaminants. In contrast, the high virulent pathogens, for example, Staph aureus or gram-negative bacteria or even Candida, there is already 1 positive sample enough to call it the pathogen. So there is no contamination with these highly virulent pathogens. However, if you want to really have a look on the crime scene, which is the surface of the prosthesis, then we can send the implant to sonication, a method which is used to remove the bacteria from the surface by ultrasound, which is the typical sonication bath, in which the prosthesis is put in a plastic container, and after 1 minute of sonication, the bacteria are removed and we can detect them in the culture. Here we see the sonication fluid versus tissue biopsies on the left from the same patient, and we see that the sensitivity is the highest, about 90%. So it is not surprising that there are numerous studies from the original one, which was published in 2007 to until now, in looking at different implants, not only joint prosthesis. So in conclusion, we suggest to use intraoperative at least 3, better more tissue specimens, and in addition sonication, which was shown in this study from Oxford, showing that sonication here in triangles is or in the round symbols is always adding to the tissue biopsies about 5 to 10% in sensitivity and also in specificity. So we have the most important, the puncture as a preoperative investigation, and we have the sonication and the tissue biopsies as intraoperative sampling, which we can adapt if they are acute or chronic infections. So in the acute infections, we do the revision, whereas in chronic infections, we go for complete exchange of the prosthesis. This is already the treatment part. When we have an hematogenous suspicion, we should not forget to take blood cultures and investigate the potential primary focus. And in those invisible prosthetic joint infections, which with loose or just painful prosthesis, the joint aspiration is the main investigation. These diagnostic and but also treatment concepts are summarized nicely in this open review article. And with this, I thank you for your attention. We can now proceed to the second talk, which will be presented by Fabrice Fiorenza. And your topic is very interesting. Are the ways to prevent infection in megaprosthesis? Fabrice, please.
Thank you, Andre. So bone tumor patients are risky patients. We know that because of the type of surgery, because of the wide surgical approach, and because our patients have bad immune system, because of cancer, because they have chemotherapy, and because they have radiotherapy, either pre-op or post-op radiotherapy. And so we know the risk of infection, for example, after post-op radiotherapy is around 35%. So this leads to a risk of infection, which is around 8 to 20% in this systematic review published a few years ago. So what can we do to try preventing infection and decrease the risk of infection for our patients? So we should take precautions as we would for general orthopedic surgery for our hips, knees. And so we should try to decrease the risk factors, especially diabetes, or we should improve nutritional factors like albumin, iron, protein, vitamin D, or zinc in order to reduce the risk of infection. And so at the ICM meeting about 2 years ago in Philadelphia, the experts pointed out the specific risk factors of our oncology patients. And so it's important to decrease some of them, like the duration of the surgery. So we should try to shorten our operating times as much as we can. Other bad factors are pre-operative hospitalization more than 2 days. For the proximal tibia, long resection, 37%, 35% of the bone, or if when resecting 3 or 4 heads of the quadricep versus 1 or 2. Same thing with post-operative blood transfusion, 2 units, more than 2 units, or a post-operative hematoma, or the need for additional surgical procedure. All these are risk factors which tend to increase the risk of infection, so we should try to decrease them. For example, should we delay surgery in case of neutrophil count less than 1,000? Of course, yes, we should cancel surgery and delay it. The time delay between pre-op CT and surgery should be between 3 and 6 weeks following radiotherapy in order to decrease infection. And then we have surgical strategies. Should we modify our strategy for certain patients? For example, the type of reconstruction. Maybe for some patients, like, for example, Ewing sarcoma of the pelvis, if at the MDT we plan a preoperative radiotherapy, maybe we should limit reconstruction, avoid the big prosthesis made of metal, or even though do a no reconstruction for our patients. Limited reconstruction like a hip transposition are also less risky than big megaprosthesis. For example, in this study, in this article reported by Eckert and this group in Los Angeles, they had 8 patients who had hemipelvectomies, and functional results were very good with a mean MSTS score at 73%, and there were no infection. And so I think we should think of these flail hips for our patients. Hip transposition, in this article, they show that the risk of infection with this kind of operation is around 17%, which is less than traditional megaprosthesis or allografts. Even for a type 2B reconstruction where you use a megaprosthesis, proximal femur, the risk of infection is around 17%. So these are ideas to consider for our patients in some specific indications. Coated implants, can they help? Silver coated implants, iodine implants. Well, the ICM say yes, we should offer silver coated prosthesis to be used for reconstruction of our patients after primary bone tumor resection. Iodine prostheses are quite popular in Japan. In this article, the risk of infection in the prophylactic group was around 5%. So in Europe, silver-coated prostheses are much more popular. Why? Because they are safe with lack of toxicological side effects. There may be some local side effects like with argyrosis, but it's not a big deal locally. In this paper published more than 10 years ago, the Munster group showed that the risk of infection for silver-coated proximal tibia was around 7%, where in comparison it was 17% for non-silver-coated prosthesis. A few years later, same group, more patients, more follow-up, and still the risk of infection for silver-coated prosthesis was around 9% compared to 17% for the non-silver-coated prosthesis. And this is the Birmingham paper from Azim Wafa, which showed that for primary reconstruction, if you use a silver-coated prosthesis, the risk of infection is around 11%. If you use a non-silver implant, you double this risk. And this was statistically significant. Soft tissue reconstruction, that's very important. And I think we should use our colleagues in plastic surgery as much as we can to decrease the risk of wound complication. We know that the gastrocnemius flap significantly reduced the risk of infection around the knee for proximal tibia EPRs. This was shown more than 20 years ago by Rob Grimer in a nice paper who showed that you decrease the risk of infection with your flap. In this paper, our Japanese colleague showed that it's a short series, but with a ram flap, they had no infection for hemipelvectomies. So maybe the ram flap is to pelvic surgery, what the gastro flap is to reconstruction of the proximal tibia. We have to think about that. Pressure wound therapy dressing. This is an interesting technique. It's well published by our colleagues in vascular surgery. It helps wound, and I think for our risky patients, we have to think about this technique to decrease the risk of infection and the risk of wound breakdown. There is an interesting paper published in the Journal of Arthroplasty for hips and knees. So why not use it for tumor patients? Does operative time matter? The ICM says yes, and we should try to choose the operation which is as quick as possible. When should the drain be removed? Within 24 hours of surgery? The type of draping. There is evidence that with using iodine draping, you can have a reduction of bacterial contamination at the surgical site, but doesn't mean there is very little evidence that we can decrease the risk of infection for our prosthesis. But it's probably better, but we don't know. And now the problem of the antibioprophylaxis to prevent infection. So it can be given IV, or there are also a local way to give antibiotics with local biofilm disruptors. So the ICM, if you use an EPR, ICM advised that the antibiotic prophylaxis should be the same as conventional total joint arthroplasty, so hips or knees. But if your patient have had chemotherapy or radiotherapy, then we should extend this antibiotic prophylaxis, or maybe use 2 antibiotics. So this is what the parity trial tried to show. It was an international trial, randomized, double-blinded, and 600 patients were included. And they tried to compare 5 days of cefazolin post-op versus 1 day of cefazolin post-op. And so the final results haven't been published yet. I haven't seen them, but there is a significant difference between the 2 protocols, but it was not statistically significant, I think. But I think we have to think of our risky patients, and giving 5 days of antibiotics, I think makes sense. We can discuss this with Andre afterwards. Locally, the gels like the DAG, the defensive antibacterial coating, you apply them to the surface of the implant. It's used for cemented orthopedic prosthesis, trauma implants, or megaprosthesis in oncology. The aim is to prevent the early biofilm formation, and you can add antibiotics as well. There is a quick release at 2 hours, and it's rapidly absorbed within 72 hours. There were animal studies showing, interestingly, that up to 99% of the bacterial load could be reduced. In this paper, comparing a two-stage revision procedure for infection in hips, the DAG group had no reinfection. It was not statistically significant, but it's interesting. Pellets, they are absorbable calcium phosphate. They can be left in the wound or in dead space for a period of 3 to 6 months. The interesting thing is that the intraarticular levels are up to 1,000 times the one you have with IV administration. So there is a good release, and maybe it's an interesting way that we could think about. So in conclusion, in order to prevent infections in EPR, we should try to control the risk factors. We should try to decrease our operating time. We should think for specific indications of limited reconstruction or no reconstruction. We should use silver-coated implants or iodine implants. We should work with our plastic surgeon colleagues to enhance soft tissue reconstruction. I think it's a good idea to use vacuum dressing for these risky patients. We should talk with our infectiologist and think about antibiotic prophylaxis. Maybe it makes sense for risky patients to use 5 days of antibiotics. And local biofilm disruptors might be a good idea, but we need more follow-up. Thank you.
Thank you, Fabrice. It's some very interesting points you mentioned, and we have already some comments in the chat. We will discuss it after the next talk. So I will ask now Volker Alt. Volker, thanks for joining us with your talk about the new classification based on the TNM classification of tumors. Please.
Thank you very much, Andre. Yes, I would like to present a new classification system for periprosthetic joint infections, and including infections for megaprosthesis. So the presentation I give and the classification I present here is not an oncology classification of the tumor, but it's a classification of the periprosthetic joint infection, which is based on oncology aspects. Because we do not want only look at the microorganism. We know that when we deal with infections, we also have to look at the implant, and particularly also on the host. And for this classification, we include all those 3 important subjects. We include the microorganisms, the host, and the implant. Because if you look at those different implants, you know that there is a difference in the way you can treat those infections, whether you have a standard implant or this proximal femur replacement or even a total femur. So the type of implant really matters what different therapeutic options you have. And also the soft tissues matter. It matters whether you can do it by yourself or whether you need the help of a plastic surgeon, like in this case on the right-hand side. The other important aspect in PGIs is the pathogen, particularly its antibiotic susceptibility. And for this classification, we want to include also the host, because we know if you have a healthy host or if you have a really a very sick host with a lot of comorbidities, this also matters for your treatment decision. And we want to work on those different aspects in order to get a better classification of our periprosthetic joint infection. So we focus on the local aspects, which are the implants, the soft tissue, whether it's a standard or a revision implant, for example. Then we look at the next aspect, which is the bacteria. And for the bacteria, we differentiate whether the bacteria has already been able to form a mature biofilm or not. We know that the maturity of the biofilm depends on our treatment decision. We know that there are difficult to treat bacteria, for example, rifampicin and ciprofloxacin resistant microorganisms, or even fungi make the situation more difficult. And we also want to look at the comorbidities of the patient. We have to ask ourselves, is the patient really capable for anesthesia or a two-stage exchange, particularly in the megaprosthetic settings? And if we combine all those aspects and take that down to tissue and implant, non-human cells for the bacteria and morbidity, we come up with the three big letters T, N, and M. And all of you know that this is a successful T&M classification that is used in oncology, like shown here. Because with this new classification we want to present, we want to rely on other successful established classifications in order to make the introduction of such a new classification easier for all of the uses for example, for us surgeons, but also for microbiologists and so on. So this is an overview on the three letters that we address. It's the T, it's the N, and the M, tissue and implant conditions, non-human cells, and morbidity of the patient. We published this last year together with Andre in order to have a more comprehensive view on the underlying PGI. If we look at the letter T, what do we want to express with the T? T for tissue and implant conditions. We differentiate between a stable implant or a loosened implant. A stable implant is the T0 and a loosened implant is the T1. And in conditions with a very severe soft tissue defect that requires plastic surgical repair, this is then a T2. So with the T0 to T2, the situation is getting more complex, as it is also in oncology. Then we also differentiate between A and B, because A always represents a standard implant, and B is the revision implant or even a megaprosthesis. So a situation T0A means that this is a stable standard implant without an important soft tissue defect. Then we go to the next letter, which is N, non-human cells. This includes the bacteria and the fungi. And here we focus on the differentiation of the maturity of the biofilm. In the N0 situation, we have an immature biofilm. which means for our treatment decision that implant retention can be considered in those cases. And the N1 and the N2 do represent situation with a mature biofilm. And for the mature biofilm, we then differentiate the underlying microorganism regarding their antibiotic susceptibility. N1A is a easy to treat pathogen, and N1B is a culture negative infection. Situation is getting even more complex in the N2 situations. N2A is a difficult to treat bacteria, for example, a rifampicin resistant Staph aureus. In the N2B, we have to face a polymicrobial infection, and the N2C, an infection with fungi. And then last but not least, we look at the patient and particularly at his comorbidities. We do differentiate, for example, as it is also done for chronic osteomyelitis by the Journey-Mader classification. We do differentiate with the M0 patient, which is more or less a healthy patient. Then the M1 patient is moderately compromised. This is confirmed, or this is diagnosed with the Charlson Comorbidity Index. And the M2 is a severely compromised patient with a Charlson Comorbidity Index between 4 and 5. And the M3 situation is a situation where we have no surgical option, because either in the M3A, patient refuses surgical treatment, M3B, patient does not benefit from surgical treatment, or M3C, which means that the patient does not survive surgical treatment, which means that he does not tolerate a general anesthesia. Another important aspect that we wanted to include in that classification system is the fact that reinfection of a prosthesis is also a negative predictor for the outcome for the situation, and therefore we included the R as a sign of reinfection. And I want to give you one or two examples for that. This is once more the overview of that, the T, N, and M, and also the R, looking at the situation, whether the situation is reinfected or not. So this is the first example for that, a chronic hip infection patient. He's 86 years old. You can see a photograph of him lying in his bed. You see that he is severely compromised. He has had several myocardial infarctions. He had the CPR 2 weeks ago. He's on dialysis, diabetes mellitus type 2, and he has a Charlson index of 7. He had the proximal femur replacement 2 years ago after aseptic revision arthroplasty, but he has no soft tissue defect. Puncture then brought a polymicrobial infection with the growth of Staphylococcus epidermidis and Enterobacter cloacae. So if you want to diagnose that, if you want to talk to one of your colleagues about such an infection, it's very difficult over the phone to explain the entire complexity of such an infection. And for this, we have this classification that enables a better communication for such infections. Because if you look at that, you see that the patient has a revision implant, but it's not loosened, at least not from the X-ray. So this is a T0B situation. So we have a polymicrobial infection 2 years after the revision of his first prosthesis, but he has no acute infection, so we have to assume that this is a chronic situation. So with a polymicrobial chronic situation, we have an N2B situation. Regarding his comorbidities and the overall morbidity of the patient is a so-called M3C patient. He was not cleared by anesthesia because they did not deem him adequate for anesthesia or surgery. So the situation for this patient was an M3C patient that could not be operated on. And the communication and the diagnosis for this complex situation is a T0B, N2B, M3C situation. Another case, this is the case that I presented during our first seminar. You have this relatively young patient, 39 years old, with a chronic infection of a total femur. He had multiple revisions, and he had this draining sinus, we grew a Staphylococcus hemolyticus with resistance against rifampicin and ciprofloxacin. And if you analyze this situation, you come up with the diagnosis and the classification of a reinfection of a revision implant. Did not see any implant loosening, so this is RT0B. We did detect relatively easy to treat, no, it was difficult to treat bacteria because it was rifampicin resistant from the Staphylococcus aureus point of view, so that's a difficult to treat organism. So it's N2A. The morbidity of the patient is not very high because the only underlying disease he had was his Ewing sarcoma 20 years ago. So this is an M1 patient, only moderately compromised. And the overall classification of this situation is RT0B, N2A, M1. This might sound complex, I agree, but the underlying disease is also complex. And I feel that PGI is a complex disease that needs an adequate classification system that also guides our treatment decisions. In order to help the handling and the working with that new classification system, we developed an app that can be used with your smartphone. We have started that with, or in German language, for the first German application for this. Looking at the T, you can enter here the affected joint, and then you switch to N, where you type in the information on the bacteria, and then also you type in the information about the comorbidities of the patient, and then the system gives you the diagnosis for this underlying case, and this is now available hopefully in 2 weeks, at least in Germany, and we are also working on an English version of that. And we hope that with this app, we can help to use that classification system in the future for the clinical use, but also for scientific use in order to better classify patients for clinical studies. So please let me summarize that we try to develop a system, a classification system that takes into consideration not only the underlying microorganism, but also the implant, soft tissue conditions, and the comorbidities of the patient. We want to have that classification system in order to help us to guide our treatment decisions. We cannot resolve that important problem with the differentiation between acute and chronic infection, but we think that with the differentiation between mature and immature, we can get into a better communication with that. We need to validate that, but we are in the process of the validation of that new system with our patients. Thank you very much for your attention.
Thank you, Volker, for this very nice overview of a complex situation. We have a couple of minutes now to discuss, and I would like to ask both of the other two faculties, so Lee and yeah, thank you, and Fabrice to join us. And we have already some questions in the chat. Maybe I would start, I think most, Fabrice, were questions to the study you presented, Parity. It's a study, as I know, it's not finalized yet, but quite a lot of patients, 600, comparing cefazolin 1 day versus 5 days. Would you comment anything on that more? Because I think if this study will show that 5 days is better than 1 day, it will probably have an influence. What is your thought on that?
Well, my thought is we had this discussion about 15 years ago with my infectiologist, and he was really against giving 5 days of antibiotics for antibiotic prophylaxis, because infectiologists, they don't like to give 5 days of antibiotics because they don't want to select the germs. But these patients are risky patients. They have a bad immune state. So I consider when I operate, I do it the French way. So after my operation, they are infected. So I said to my infectiologist, what can we give them to treat this infection, which has been generated by the operation? And he said, well, cefazolin 5 days. So since 15 years, for all under prosthetic replacement, we give 5 days of cefazolin, and we still do that. And so the parity study showed there is a difference, but as you said, as far as I know, it was not statistically significant. But I think it makes sense to give antibiotics to these patients. I remember I went to some other units in the world, and some would give 50 days of antibiotics. Lee, in Birmingham, I don't remember, but I think you would give antibiotics till the drains were off.
Yeah.
Yeah,
So,
Lee?
Yeah, so I think you're going to get in trouble with Michelle because she says that the data isn't analysed properly yet. So you better be careful because Michelle's listening.
yes, I know.
Yeah, but yeah, we give antibiotics till the drains are out. So that can be anywhere between 3 days and sort of 10 days sometimes. And we use a lot of back dressings, and I can see that there's some questions about back dressings as well. But all of our high risk wounds get back dressings, but in combination with the drain. So our principle is to drain the fluid from below, but then vac on top to try and get an early wound seal.
So both of you are using, let's say, not single dose, but let's say a couple of days. And if the studies will show that, I think that all people around the world will need to accept this. If in high-risk patients, you have something to reduce the risk of infection, that's the way we should go. Because I think the most dangerous way to create resistance is repeating revisions, because you always put the patient at risk for additional superinfection. Volker, how are your experience on prolonged IV prophylaxis, antibiotic prophylaxis?
Yes, and I also like the prolongation of systemic antibiotics in complex cases, also in non-tumor patients, if this is a complex aseptic revision, or even if it's a complex trauma case. I do not hesitate to go for 3 days. I will present later on the data on the antibiotic bone cement. We know that at the time of surgery, we need to really hit hard. So we need high doses. And we also might consider a prolongation of the systemic antibiotics in those very complex cases. This is not a standard fracture fixation of an ankle fracture. This is really complex surgery with a high impact in case of infections. And therefore, I think also our infectious disease specialists like you, Andre, we do not only learn your language, but you learn our language too. And I think that you are also open to discuss with that the prolongation of systemic antibiotics in such complex cases.
Absolutely, because I think infectious disease people who are not so much in contact with you, with surgeons, they don't see what is the consequence of an infection. It's really a disaster, and in all aspects. So if you have something to reduce it, and it's very nice that you mentioned also local antibiotics. And Leah, I saw you also said also that we should do everything just to prevent infection, systemic and local. Lee, do you have any experience with local prophylaxis?
Yeah, so we use the calcium sulfate pellets routinely in our second stages, and in combination with antibiotic loaded cement in our first stage as well. So we're a big proponents of it. Some people say that they have problems with the wound afterwards. We haven't noticed that problem very much, but we're big fans of using the antibiotic-loaded pellets. Or there's also some interesting data, I think I presented last time, out of Hong Kong about using antibiotic-laden cement around the prosthesis in your first stage, which for Megaprosthesis I think is quite useful as well.
Yeah, and coating we mentioned also last time as a potential future approach, because cefazolin is quite, I would say, primitive way, because we don't cover all pathogens, especially those not on the skin, which are the most common, the methicillin resistant. So maybe there will be in the future some more, not only on the duration, but also choice of antibiotic. I think that there are no studies, for example, on cotrimoxazole as a prophylaxis, but if you give it IV, it has a much better spectrum. But it's so difficult to make these studies that it will be maybe a long time that we will have additional. But from my side, I can say from infectious disease standpoint that it speaks nothing against prolonged prophylaxis, but then we should give it IV. And all of you mentioned the IV dose and not oral cephalosporins, which is like sugar.
we have a problem in the UK that we're not allowed to use cephalosporins because we get the hospital gets fined on the number of cases with a Clostridium difficile. So as it's been shown, so routine prophylaxis in most hospitals in the UK is flucloxacillin and gentamicin, only because it has a lower C. diff profile.
So maybe cotrimoxazole or even fosfomycin would be two antibiotics which has not these side effects but has a better spectrum. There was a question, I think, for you, Volker, about what is mature biofilm. Is there any definition, is any structure or architecture that you call this is a young one and this is an old one? It's difficult in humans to say what is young and what is old. Is it in biofilm easier?
There is no real good answer because we cannot detect it from 100% from the outside. You are the expert on that, Andre, and we have only time for the moment that we use. We say if the patient develops symptoms even directly after surgery or in case of late hematogenous within 2 or 3 weeks, we do consider this as an immature biofilm, where we hope that our antibiotics can still go through the biofilm and kill the bacteria. But we know also from in vitro and in vivo experiments that the biofilm already forms after 1 or 2 days. And for time being, we do not really have an exact measurement to detect the differentiation or the evolution from immature to a mature biofilm. The only thing we can say, but that doesn't help, is the biofilm is then mature when our antibiotics do not work anymore.
It's interesting, after decades of research, we still don't know what happens in the biofilm, that after a couple of weeks, no biofilm active antibiotics are active anymore. So that would be a perfect topic for research, to look maybe in the microscopic or even smaller molecule way what happens, because maybe we can reverse the age of the biofilm and or disperse them. So just as an idea. There was a question on prosthesis in children when the endoprosthesis is growing. Does anybody has any experience on that?
Sorry, what was the question?
In children, the prostheses which are growing.
Yeah, so we moved to non-invasive growing prostheses, which was published in the Lancet. It was a very big technological advance, and it reduced our infection rate very significantly. We used to have a 3% infection rate risk every time we did a lengthening with an open procedure, and now that has significantly reduced with non-invasives. So we tend to use non-invasive growing prosthesis when possible.
How do you do it, with magnetic or
Magnetic, yeah.
magnetic?
Yeah,
Yeah.
magnetic.
This data you mentioned, Lee, is exactly the same as the spine surgeon has if they use the vector system, which you also always need to always do invasive change.
Yeah, it's all only a very small operation, just a small puncture wound, and put in an alum key. But every time you did it, at 3% risk. And so if you do 10 lengthenings, then that's 30% risk of infection.
And I can say from that vector study, we always, what we removed, we put on sonication, and we could see how over years, the bacteria which we find in the beginning, they increased in the numbers. And then finally, the infection was manifest after several years. So you can really see the biofilm is growing. Time is coming and time is running and the biofilm is coming. That's okay. Thank you very much for now. I think, Lee, you can maybe continue with your interesting cases, and we will continue with the discussion afterwards.
Okay, yeah, and sorry, we'll just get back to the beginning. Okay, so I think we're going to talk about managing soft tissues and tips and trips on debriding. So in Birmingham, we're big fans of heavy metal. We had some very famous rock bands from Birmingham, Led Zeppelin and Judas Priest and Black Sabbath. But of course, we're also very big fans of big metal, heavy metal in terms of prosthesis. And it's very nice to do and gives us very nice x-rays. But we have to remember that we need the soft tissues as well, because if the soft tissues fail us, then no amount of antibiotics are going to help us. And sometimes, as we saw from Volker's excellent talk, the comorbidities of the patient, including obesity, are a very big problem as well. So today I'm going to talk a little bit about our results. I want to show you our results because I think it shows that we're doing something right. Then I'm going to talk a little bit about what happens when we open the skin, which incision we should use, and how we manage sinuses. And then we're going to talk a little bit about some proper debridement. We'll spend quite a bit of time on showing you how we debride a joint, and then talk a little bit about closing. But Fabrice has already talked a little bit about flaps, so we'll try to skip over that as quickly as can. So in Birmingham, traditionally, we've used this rationalized individual care approach. So if we have an acute infection with a good skin, a sensitive organism, a good host, we'll do a DARE. We'll do a single stage revision in a chronic infection with a sensitive organism, a good host and a good skin. And for chronic infections with bad skin or resistant organisms or a poor host, we tended to favor a two-stage. And we'll come on to maybe an updated algorithm in my case. But you can see that for DARES, our failure rate is about 10%. For single stages, it's about 6.5%, two stages about 10%. And salvage procedures where we need to use a flap or we have multi-drug resistant organisms, then unfortunately the success rate is a lot less. I think it's important that plastic surgeons know these diagrams off by heart. We have to think about where the blood supply is to the skin where we're operating, and it's important we try not to violate the blood supply to the skin, but also to the muscles. In tumor cases, we're resecting very large volumes of muscle, and there's no point leaving any dead muscle behind. So we prefer to do intervascular planes and tend to try to resect the whole muscle if we're going to do that, to try not to leave any dead muscle behind. But in practice, this, which scar do you use when you've got multiple scars which you could use? So generally, we try to use the same skin incision as previously. We try to avoid where scars meet or create a new scar, which is going to meet another scar. And we see this particularly in a conversion of unicompartmental knee replacements to total knee replacements, where someone's had a medial parapatellar approach and then somebody does a midline incision. definitely avoid transverse incisions, and if you've got a choice, generally the advice is to go for the more lateral incision. Personally, I tend to try to use the incision that has last healed. So if we have an incision that we've been in before and that's healed, then I'll try to use that because we know that it healed last time, so hopefully it will heal this time. But also don't be afraid, as Fabrice said, to get advice from plastic surgeons. Because when it all goes wrong, we're really in a difficult situation. So you can see on the left here, someone's done a previous uni with a medial parapatellar incision and then a midline incision after that. And they have had problems with that area of skin necrosing. And then you don't need any fancy tests. When you can see the implant through the skin incision, you know that that is a infected, the so-called reflection sign. And on the last case on the right-hand side, we've got really gross necrosis, and we're going to have to think about some kind of muscle flap. So this was a patient of mine who had a arthrodesis for a road traffic accident some 20 or 30 years previously, a motorbike accident, and he wanted to have his knee arthrodesis taken down, but he'd had this very awful incision with a cruciate type incision, and I was very worried about whether we should do any surgery on him. So we performed very unusually what's called a test scar. So we opened up the wound before we did any implants. We went down to the joint and mobilized all of our flaps as if we were going to do the knee replacement. And then we took some samples from the joint to exclude any underlying infection, and we closed him back up again. And you can see that the wound was looking pretty horrible at this point, and I was very worried. So we went on because it had healed, and he was a good candidate for a knee arthrodesis takedown. And this is what it looked like at surgery. You can see that we've had to do very large flaps and lateral releases to get his knee to flex afterwards. And then we put him wound straight and put him in plaster for 2 weeks until the wound healed. So this is when his plaster came off at 2 weeks. Fortunately, the wound has healed better this time than it did for the scar. But because we'd already tried that scar, we were very happy to use it again. This is his x-rays, a hinge complex knee replacement. The skin at 3 weeks was looking pretty good. At 3 weeks, he's starting to get some reasonable movement back. At 5 weeks, he's starting to get better movement back. And at 6 weeks, now he's able to use... Next, thanks. So at 6 weeks, he's able to use a treadmill, and he sent me these videos last week, and you can see that now he has excellent function. But the point of showing the case was that if we manage the soft tissues well, then we can use the then we can get away with a complex operation. And you can see that he's now cycling 15 kilometers. So what about small sinuses then? Well, they're often, as Andre said, from low virulence organisms. There's a very low chance of septicemia because the infection has been decompressed, but you can get secondary colonization from fungi or gram-negative bacteria, and we're seeing more and more of that in our practice, and we've published our results about that. But you often can excise the sinus and close it primarily. The standard advice, if we have a sinus, is to do a 2-stage revision, but I'll show a case later where we've done 1-stage revisions with sinuses. But here you can see the patient preoperatively, quite a large sinus in the lateral retinaculum, which is always the problem, and the poor skin. You can see at the end of the first stage with an articulating spacer that we've simply excised the sinus and closed it with interrupted sutures. And we've tested the flexion of the knee to make sure that there's no blanching of the skin around the sinus where we've closed it. And you can see the patient when he comes for his second stage operation that sinus has healed up well without any problems. So one of my big bugbears in surgery is debriding for infection. If we can show the video. So an arthroscopic washout is not a debridement for a periprosthetic joint infection. We know that there is a 7 times higher failure rate for arthroscopic DARES than there is for open debridements, and so this is not a debridement. Next video. This also is not a debridement. So when you see people just scraping gently around because they're too worried about damaging anything, this is not a proper debridement. And even if you're doing a more aggressive debridement like this, you can see that using curettes and rongeurs, for me, this is still not a debridement. We need to do a full synovectomy. Okay, if we can move on. So what is a debridement? And I'd like to reference Rydian Morgan-Jones from Cardiff. He gives an excellent talk on debridement, and he kindly lent me some slides. But a debridement is a combination of things. It's a surgical debridement, which means explantation of the implants and then a complete synovectomy done with sharp dissection. It's then a mechanical debridement with a curettage, reaming and lavage. And then it's a chemical debridement, either with an antiseptic such as iodine or chlorhexidine. If you're Rydian Morgan-Jones, you like to use acetic acid or honey. And some of the companies now are using anti-biofilm as surfactants such as Bacteriasure. There are other things you can use such as autolytic hydrogels, enzymatic such as collagenases, and of course for wounds you can think of biological like maggot therapy. So in your surgical debridement you need an adequate exposure. You have to be able to get to everywhere within the joint. You have to remove all of the implants because the implants are basically acting as a sequestrar. So for chronic infection, osteomyelitis, we know that it's a sequestrar that maintain the ongoing infection. So it's important that we remove all dead bone and all foreign material. And then we need to excise the membrane, and that means it's a full, complete synovectomy of the joint. And that is where your biofilm is living, because when you've removed the implants, the bacteria remain in that synovium. Charles Lautenbach was famously had amazing results for treating infection and osteomyelitis in South Africa. Rydian Morgan-Jones worked with him briefly, and I've been and visited the unit, but unfortunately after Charles had passed away, and Richard, his successor, is now doing it. But he talked about complete compartmental debridement and used to use a suction irrigation system. But what do we use? Well, we use pulse lavages on low power and high volume, which gives a tidal effect. It also allows you to get edema within the membrane and then more easily see it to then excise it. Rydian's a big fan of hydrogen peroxide, and we used to use hydrogen peroxide, but unfortunately our hospital has recently stopped us using it because of some medicine regulatory reasons. Then we do chemical debridement. As I said, Rydian's a fan of acetic acid and honey. We're starting to use Bacteriasure, but we would routinely use betadine if we're not using a silver implant. You cannot use betadine if you're using a silver implant. So if we are using implant irrigation with chlorhexidine. And the most important thing is that this is a cyclical debridement. So we do our exposure, explantation, and synovectomy, and then we curette, and then we ream, and then we lavage, and then we do it all again. We repeat our synovectomy in areas that we've missed. We curette, ream, and lavage again. And once we're happy that it's mechanically cleaned, then we'll do our chemical chlorhexidine or betadine soak, and then we will redrape after that and start our surgery for reconstruction. So this is one of my colleagues, John Stevenson, demonstrating a synovectomy. So he's opening the suprapatellar pouch here, and then you can see that he's developed the layer of the synovium, and then he's removing the synovium, attempting to remove it all in one layer, starting at the suprapatellar pouch and then coming down the medial gutter of the knee, and then coming down the lateral gutter of the knee before debriding the posterior aspect. And you can see that he's removing this chronic biofilm layer. Okay, if we can move on. So I'm going to show you a video we did on Monday of debriding a hip for a second stage. So here at the open the hip joint capsule, you can see that I'm demonstrating here the layer between the capsule and the synovectomy. The next slide, please. And now we're starting to excise the synovium away, but retaining the capsule. You can see that we are keeping it all as one layer, so a combination of sharp dissection with diathermy, or scissors, or a scalpel, depending on which you prefer. And now we're going to excise that posterior capsule synovectomy, and then we're going to release the anterior capsule so to allow us to do our subsequent debridement. So we've found where the capsule is in the synovium, sorry, and we're going to open that space up to allow us to do a dislocation. And then we're going to remove the spacer, in this case an articulated antibiotic-laden spacer. And then we're going to excise that posterior capsule, but we're now going to excise it below the layer of the acetabulum so that we can remove the synovium in the effective joint space. Everywhere the fluid can get to in the joint, the synovium needs to be removed. And you'll see here that there's the posterior synovium that we had already prepared, and now we're removing it all the way down, but you can see that I'm removing it below the level of the acetabulum. Now we're going to remove the anterior capsule. Now we can see it properly. We've repositioned our retractor more superiorly. And you can see here now that I'm removing it from anteriorly up to the neck of the femur, and we're removing all of that synovium as a single piece, all the way down to the lower level. Okay, we move on to the next one. And then, as we said, we're going to do a reamer, but this is not acetabular preparation. This is simply cleaning the acetabulum with a reamer. And then we're going to move on to the femur. So we're going to curette out the femoral canal, obviously sending all these samples off for a combination of histology and microbiology. We're trying to do it systematically. Then we're reaming the acetabulum, and if the femoral shaft. And if you look at the picture on the right, you can see a small bone sinus that is where the infection had originally gone into, which is then being cleaned. Then we're going to lavage the canal. You can see that we've elevated the knee so that fluid washes out of the femur. And then we're going to do our chemical soak, in this case with a chlorhexidine onto sponges packed into the acetabulum and the femur and we're going to leave those for approximately 5 minutes before then repeating our debridement, going back, curetting, reaming and lavaging again, and doing that cycle 2 or 3 times. Now that's a standard second stage hip revision, but if we're going to do a tumor prosthesis, then we're going to end up with the same principles, but a much larger debridement. So here we have a single stage revision for a proximal tibial replacement, which is infected, and we'll talk about why we did a single stage revision another time. But again, identifying the layer between the mature biofilm and capsule and the normal tissue, and then trying to debride all of that after removing the implant at the same time. And you can see then that we've removed all of that layer as a single layer to give us a healthy bed to do our reimplantation into. And after you've finished, you end up with healthy bleeding tissue in which your antibiotics can get into, but also you have no longer any biofilm left. So this is a case example of an infected hip replacement, and you can see here a very awful infection, and we do our debridement, get all the biofilm layer out in a single time, and you can see that this is at the end of our debridement. So we've gone from this situation at the start of the operation to looking like this at the end of the operation, and then we've done a spacer in this case. And at the second stage operation, when you go back in, you can see how clean it is at your second stage without a need for further redebridement. And again, we've used some silver-coated implant with some calcium sulfate there. So what do we do when it goes wrong? Well, you have to make sure that you don't make things worse. If you're going to do surgery like we've demonstrated, very large tumor resections, you have to either be able to do your own flaps or you have to use a plastic surgeon. Make sure that you have a good relationship with your plastic surgical department and call them before the case rather than when you've realized that you've made a mistake. In terms of the reconstructive ladder that they'll tell you about, we like VACs to help well covered wounds heal, but we don't like VACs just to put on a wound that is looking already like it's not going to heal. Sometimes you're very lucky, you can get away with a primary closure and excision of the wound, but secondary intention takes many, many weeks for it to work and is generally best avoided. For large defects, particularly around the knee, we're big fans of gastrocnemius flaps, and Fabrice showed you that they're a very reliable flap and that they're very straightforward to do. We do all of our own gastrocnemi flap in revision knee replacements, and we've just about to publish, it's under review at the moment, 27 gastrocnemius flaps for patients with infected knee replacements, and we had 100% flap survival with no early returns. 3/4 of patients who had a knee revision and infection with a flap maintained their leg, but there's about a 50% reinfection rate. Very rarely do we need to use free flaps, but this patient had had a combined proximal and distal femoral replacement and distal femoral and proximal tibial replacement, and therefore we needed a free latissimus dorsi flap. And this is what the wound looked like after the first stage, and now we have a healthy bed to do a secondary reconstruction. So in conclusion then, remember the skin, remember that plastic surgeons are your friend, don't make it worse. If you're not sure, refer the case to somebody who does do this. Gastrocnemius flaps are really, really good, but importantly, your debridement should be radical, aggressive, thorough, complete, tumor, and most importantly, it should be cyclical. Thanks very much.
Thank you, Lee. This was really impressive, and I think everybody will remember now what is the thorough debridement also from the non-surgical specialties. And you mentioned several times a good relation to plastic surgeons. That is, I think, a very good point. Maybe Fabrice, if you can also join us for a short discussion. And first, I saw there was a question for you in the hip debridement video, where the question was that a standard posterior approach?
Yeah, we do all of our hips through a standard posterior approach. You can extend it into a Cocker-Langenbeck type approach if you need to go further posteriorly or superiorly. I know that perhaps in Germany, some people are big fans of the anterior approach, and I think it would probably be very difficult to do a good debridement through an anterior approach. We prefer a posterior approach, but I don't know, Volker, do you do an anterior approach for debridements or posterior?
For anterior approaches, we do some kind of primary hip surgery for a minimal invasive anterolateral approach, but with a pure anterior approach, it's very difficult to access the entire joint, and this would not be feasible for a revision of a tumor prosthesis. Even the implantation of the tumor prosthesis would not be feasible with the pure anterior approach.
And I showed quite a lot of things about the knee, but I think the most important thing is applies to hip or knee or shoulder or pelvis, is that you need to have a good exposure to be able to see the whole joint, because it doesn't matter, the bacteria don't care if they're hiding right around the front or right around the back. You've got to get to them, so it's very important you have a good exposure.
Fabrice, which approach would you recommend?
Posterior.
Or do you use?
Yeah, posterior, and you can do ETO, extended trochanteric osteotomy, if you need it to remove all the cement, for example, or as Lee said, you can extend it with a Cocker-Langenbeck.
Lee, there was another question why synovectomy was done before the second stage and not before the spacer placement.
Yep, so we do it at both stages. So I think what you have to remember is that Hansen showed that 10% of aseptic loosenings, and if you look at some of the data, it's even higher than that, 20%. We know that we have a second positive culture rate in our second revisions. So we do a synovectomy at the first stage and the second stage routinely, because no matter how good we think we've done with our first stage, in about 10% of cases we will have a positive second culture. And then I know in my heart that I've done the best operation, and I can say to the infectious disease doctor, well, we've redebrided everything, and so essentially I've done another first stage operation, and therefore our extended antibiotics are more likely to work. So I think it's very important that we do a synovectomy at the first stage, but also at our second stage.
So that shows that probably that is the most important determinant of a good or bad outcome.
Yep.
It's insufficient debridement, and if you do a 2-stage or even 3-stage, use all opportunity to debride the necrotic tissue and remove any foreign body if there is any inside. Please, Volker or Fabrice, if you have any comment or so, you can just add. Otherwise, I have one point which I like now, especially from the infectious disease standpoint. You mentioned 2 biological treatments. One was the maggot therapy, and the other was acetic acid. Are you using them as well?
So we use maggot therapy on wounds to debride the wound before surgery, very, very rarely. We don't use routinely acetic acid, but the new biofilm lavages that we talked about, like BacteriaSure, they actually contain acetic acid and they contain surfactants. So I always say to my fellows that you know, when you were a child and you went to the dentist and they gave you that stuff that you put in your mouth and showed you where all the tartar was?
Yes.
If we could put in we knew where all the infection was, our life would be a lot easier. But we don't, so we have to use everything we have to try to get rid of the infection.
Yeah. Do you use in France maggots?
No, we don't.
They only eat them.
We don't.
Snails,
we eat frogs, we eat sails, we eat a lot of things, Not the maggot yet.
The maggot eat only us, but unfortunately only the dead tissue, and therefore it's probably the perfect debridement, right? Because they are not touching the living tissue, only the dead tissue, because they can digest only the dead one. So it's a best probably debridement. And you mentioned also don't use, I think, betadine in silver coated.
Yeah. So silver coated implants, they basically use free silver ions. And so if you use betadine, which is iodine, it turns the silver into silver iodide, and therefore you don't have any free floating silver ions. So a contraindication to betadine is silver. So we use betadine lavages in non-silver cases, and we use chlorhexidine lavages in silver cases.
Okay, chlorhexidine. Yeah, and hydrogen peroxide. I saw that many German hospitals are using it. Volker, do you have experience with that?
Yes, I do have, but I don't use it anymore because it's very aggressive to your soft tissues. Yeah. And we saw from this perfect talk from Lee that we want to have nice tissues, nice soft tissues that heal. And even with those solutions, we can really be very aggressive to the soft tissue. I personally use, and my team, we use a hypochlorine solution, which has the advantage that it's very good to the soft tissue, so it's not very harmful. And you don't have to wait for like 5, 7, 8, 10 minutes in order to have an effect of it, because it's effective already after 10 or 15 seconds. And you can also use it in septic arthritis in native joints, because it's not cytotoxic to the cartilage. And therefore this has become our standard antiseptic solution for septic procedures, let it be prosthesis or let it be native joints.
So hypochlorite better than hydrogen peroxide.
Yeah.
And that is actually the bleach, right? Or in French you call it javel, right?
Yeah.
Yeah, so, but very diluted. I think the concentration is very low, 0.05.
It's very low, but it's very effective. And also other disciplines like the abdominal surgeons, they like to use it because it's not harmful to the soft tissues.
Mm-hmm. Yeah, we've stopped using hydrogen peroxide for the same reason. And there's actually now in UK, the regulation authority, the MRHA, has recommended not using it anymore.
And there was maybe one last question, Lee, for you. Why the gastro flap should be performed in case of poor soft tissue coverage in the second stage and not during the first stage?
Yeah, so I always perform it at the first stage if I can. So if I think that it's not going to close the skin, or the skin defect is too poor, then we'd always do it at the first stage, because 2 reasons. One, you get good soft tissue cover straight away. Second reason is that you're bringing in healthy tissue with a good blood supply. And we know from osteomyelitis that flap and infections help to reduce your reinfection rate. So we always do a gastroc flap at the first stage. Occasionally, I'll close a sinus and I've got it wrong and it doesn't heal, and then I'll do my gastroc flap then, but normally always at the first stage.
Mm-hmm. I think it is really good to mention the best treatment of an infected surgical site is a good vascularized flap. Yeah. So not waiting until the infection is cured and then put the flap, but the flap is part of the treatment. Yeah. I think a very good point. Fabrice, I think this question is more for you. It was the question is your experience with infected tumor prosthesis after radiation therapy. I think you had last time this topic, or was it somebody else?
Yeah, so we know that we published a paper many years ago that showed that there was 30% with postoperative therapy, a slightly lower infection rate with preoperative radiotherapy.
Okay, good. I think we are now ready for the next 3 short cases. And the first will be presented, Volker, by you. Bone cement and antibiotic release. Volker, please.
Thank you very much, Andre. I want to talk about bone cement as a local antibiotic delivery system. And we know that the release of the antibiotics do depend on many factors, particularly on the product itself, due to the composition of the powder and the liquid, because it depends on the surface, on the roughness of the bone cement, on the porosity, and on the wettability. Also, the release depends on the type of the antibiotic and the amount of antibiotic we add to the cement. And it also depends on the mixing technique, whether you use a vacuum mixing or hand mixing. So you have to know about your product that you use, because not all commercially available products do have the same release kinetics for antibiotics, because this depends, as I said before, on the chemical compounds of your cement. And therefore, please look at the release kinetics of the antibiotic-loaded bone cement that you use. Because if you look at this slide, you see the different commercially available products, and you see that there is some cements on the market that release only a very, very low amount of the added antibiotic, whereas there are other products that do release much more of the cement that is added. And as we want to have, particularly in infection, a good release of our antibiotics, we need to be aware of the release kinetics of the products that we use. When we talk about bone cement and antibiotics, we need to make sure which indication that we are talking about, because there are different cements for different indications. And today we don't have time to talk about the fixation for standard primary surgery. I want to focus on the fixation in patients at risk for infection, and also then for the treatment of infection. Because there is really new and good data showing us the importance of a good local antibiotic release of the cement in patients at risk for infections. For example, patients with a femoral neck fracture that need hip hemiarthroplasty, that really do benefit from a good local antibiotic prophylaxis, as shown in this paper, which is called the Fractured Hip Infection Trial. In this paper, 2 different patient cohorts were compared in a prospective manner. One cohort only got the standard low dose, a single antibiotic cement loaded with 0.5 gram of gentamicin, where the second group received the high dose with 2 different antibiotics, with 1 gram of clindamycin and 1 gram of gentamicin. And the study design was very good. It was a prospective randomized controlled trial with an inclusion of over 800 patients, with more than 400 in each group. And the results are quite convincing, showing that the improved local antibiotic prophylaxis with the high dose dual loaded antibiotic cement significantly reduced the risk of infection in that group compared to the low dose standard cement. Infection rates came down, as you can see here, significantly for the deep surgical site infections, and also for the deep and superficial in a significant manner. This was confirmed by other clinical trials that also showed that the use of high dose antibiotic-loaded bone cements in patients with femoral neck fractures, that they have a significant reduction of the infection rates. And this shows us the importance of a good local antibiotic prophylaxis, which is also the case and which is also needed for such complex procedures that we are talking about in this webinar. Why is this? Because we have a much better release from the high dose and dual loaded antibiotic cement. If you look at the release of gentamicin here at the bottom, you see that the release from this single and low dose cement is pretty low, whereas it goes dramatically up in this dual loaded high dose antibiotic cement. And not only the gentamicin goes very high from the release, but also the vancomycin. And with this local protection from the local release of your antibiotic loaded bone cement, we do get a significant reduction of infection rates in patients at risk for infection. And here you can see the in vitro experiments, they show that the dual loaded antibiotic cement does really have a significant effect on the growth of Staph epi compared to the other cements. This is also now confirmed not only in femoral neck fracture patients, but also in revision, total knee arthroplasty. And we all know that even aseptic revision does include a high risk for infection. And in this nice publication from Spain, the authors could show that they can significantly reduce their infection rates if they use a high dose dual loaded antibiotic cement with gentamicin and clindamycin in comparison to the standard low dose gentamicin cement. So this is all data that confirms that the better and the higher the local antibiotic concentration from the bone cement is, the better the clinical outcome for the patients in respect of reducing the infection rates. So what about treatment of infections? We know that for 2-stage and 3-4-stage procedures, we have to use spacer also for the dead space management. And there is a lot of criteria that have to be considered for the loading of the spacer cement with antibiotics. We know that the release rate depends on many factors. And this is something that you can then read on the slides that you get afterwards. We know that also one specific antibiotic does release differently from different bone cements, and this is also something that you should know when you use a specific bone cement with a specific type of antibiotic. For spacers, this is from Andre's current version of the pocket guide. You see that the normal percentage that we use is around 10% of the amount of the PMMA powder. So for a standard 40-gram amount of PMMA, we can use 4 grams of antibiotics. And this is the standard situation. You have 1 gram of gentamicin, 1 gram of clindamycin. This is also how I do it. I add 2 grams of vancomycin in the standard situation. But if there is special situation, you can get good advice from the pocket guides for the loading of your spacer. For the spacer, use hand mixing because you want to have a good porosity or high porosity of the cement within the spacer, because this is then good for the release of the antibiotic from the spacer. And for the spacer, we do not need to look at the fixation properties regarding mechanical stability. We want to have a very good release from the antibiotic cement. You can see here the release from the spacers is not so high because the relation from the antibiotic loading compared to the surface is not so good. If you compare that to the old-fashioned PMMA beads, which have a much better surface versus antibiotic loading ratio, you see that the release from the PMMA beads is much higher compared to the spacer. there's a good review that was published 2 years ago that shows the published combinations of different cements and with different antibiotic loadings. There are combinations with up to 8 grams of antibiotics in the 40-gram cement powder, which is quite high. Because we also need to look at side effects, and there's one specific side effect that we should keep in mind and that we should look at in our patients when we use high dose loaded antibiotic spaces, and this is the acute kidney injury. This is a nice review on all published cases, and there's good advice how we should treat our patient, how we should follow our patients when we use that high dose antibiotic loaded spacers. And we should definitely identify high risk patients with chronic kidney disease, diabetes, obesity, and high comorbidities. This is more or less every patient that we treat with complex infection situations. Therefore, we need to really pay attention to that side effect. We should look at, we should avoid that non-steroidal anti-inflammatory drugs. We should pay close attention to the postoperative urine output, and we should follow serum creatinine daily for at least 2 to 3 days in order to check for that acute kidney injury in those patients. The last topic, treatment of infection, when we go for the second stage or even in first stage, when we then fix the patient, when we fix the cement in the patients, there's also a good guidance from Andre's pocket guide. We can add specific antibiotics to the cement even for the fixation. It is not as high as for the spacer cement, but it really adds to the improvement of the local antibiotic situation for the patient. Please let me summarize. Antibiotic-loaded bone cement is your friend. It helps you in primary and revision cases or even salvage procedure for the local delivery of antibiotics. Use dual-loaded high-dose antibiotic cement for infection prevention for patients at high risk for infections, and optimize the loading of your spaces depending on the causative microorganism, and avoid acute kidney injury in your patients. Thank you.
Thank you, Volker. You also answered now the question which was put in the chat before regarding the evidence of local antibiotics, both in prevention and treatment. And thank you also, Lee. You answered a second question. What is the total amount of vancomycin in the spacer? And Volker, you mentioned 10%, right? Which is
for antibiotics, it's around 10%. As I said, there is also data that do add more, but my standard is to use 4 grams per 40 grams of powder.
Lee, do you use sometimes more than 4 grams of vanco?
No, but we will add often meropenem as well. So we'll do, say, 4 grams of meropenem, 4 grams of vancomycin, 2 grams of meropenem, and it's important that you can add in the organism. And of course, that's very important as to why we do our aspiration beforehand, because there's no point putting in antibiotics into the spacer where there is not the sensitivity required.
Mm-hmm. And so you said 4 grams of vanco and 2 grams of meropenem. I think that is a good way to improve the release of antibiotics. If you make it more porous and you use more different antibiotics, so you have actually higher concentration. And that was actually the third question in the chat. Would you combine 2 antibiotics? And I think we all agree that yes, you should combine, and you can go up to 6 or even 8 grams of total amount of antibiotics per 40 grams, because the spacer doesn't need the mechanical stability. It's more the release system.
The one thing that I wanted to mention was about antifungals. So you mentioned in the pocket guide that you need to use lyophilized amphotericin if you're going to use it in the spacer because it's heat stable, whereas ordinary amphotericin is not heat stable, so it denatures. But of course, that's a big advantage of using stimulant, is that you can put the antifungals into the stimulant and the antibiotics into the antibiotic loaded spacer. So we'll routinely do that if we have a sinus. We have a very high rate of fungal infections, and we've published on that, and it's very difficult to treat. So it's good that you can use different antibiotics in your spacer and then some antifungals in the local delivery.
That's an interesting technique, because in spacer only a couple of percentage of antibiotic you put in also goes out.
Yeah.
Whereas in resorbable material, everything goes out after resorption. Volker, did you try also this approach to combine cement as a non-resorbable PMMA and a resorbable?
Yes, I was already running out of time. That's why I couldn't add the calcium sulfate. But this would be an interesting topic for the next webinar we give. But this is also the logical consequence of our discussion. The better, the harder you can hit with your local and systemic antibiotics, the better it is. You need the excellent debridement, and you need a very high local and systemic antibiotic concentration. And if you can add the calcium sulfates as an adjunctive, that's very good.
Hit it early and hard. A very good point. Now for the next talk, Fabrice, you have, I think, one interesting case, 10 germs and 1 fungus. Please.
Okay. So this is a 50-year-old patient who had ankylosing spondylitis, Crohn's disease. He had a right THR in 1985, as you can see on the slide. It was an old model called the Lord prosthesis, absolutely impossible to remove. And the left THR in 1990. And so in 2006, he developed a right hip infection, which was treated elsewhere with first a washout, then the THA was removed, the spacer was inserted, and there were all these germs that were found. It didn't work. The patient had a new debridement, a new spacer. The infection was back again, and he was sent to our center. When we received it, he had 3 fistulas at the lateral aspect of the thigh. So we did check out the CT scan, and there was a fistula at the recto-sigmoidic junction and the psoas abscess, which explained why the infection came coming back. So we talked to our general surgeon. He had a Hartmann, a left colostomy. And so I did a new debridement with a spacer, with antibiotics, vancomycin, 4 grams per pack. And he had this augmented antibiotherapy with tazocillin, vancomycin, cotrimoxazole, and fluconazole. So because of the bone destruction, I chose to remove the proximal femur. And so he had a revision 3 months with a silver-coated Megaprosthesis. And so it worked quite well for 3 years. And I came back 3 years later with a new infection, still a fever, no fever, but a fistula at the lateral aspect of the right hip, no pain. And there we found the Candida glabrata, which was interestingly the same germ that we had found on a Hickman line 3 years before. I did a left aspiration of his left hip, and there was no germ. So this is, I think we could vote. What would you do? Who would do a debridement, 1 stage, 2 stage, a tear, or I don't know, suppressive antibiotics? What else? So we can wait for a few seconds for this tricky patient. So a few more seconds. I think we are done. So next slide. So we suggested a two-stage revision procedure in this case, but the patient refused. And we refused the one stage as well. So we did a DARE with a triflucan. So he was very happy because it was a quick operation. He was out from the hospital very quickly. It worked for a year, nearly a year. Then he came back, and this time the left hip was painful. Aspiration of both hips, and then infection of both hips with Candida glabrata. So now the two hips are infected. So we discussed this case in our MDT. And so this time we strongly advised bilateral two-stage revision surgery with bilateral spaces with voriconazole, VFen. So I put 400 milligram of VFen in the left spacer and 600 milligram in the right one. Then IV Candidas for 3 months. And after 3 months, I did the bilateral hip revision with the right cemented silver-coated mutas on the left cemented hip. Silver is active against Candida glabrata. We had asked the implant cast company for this information. So nearly 3 years later, the patient was happy, was fine. No follow-up because he died of other cause after that. But the take-home of this case is that at that time there was not a lot published in voriconazole, and so we wondered if voriconazole was stable in cement spaces. And so we did these aspirations showing that at 1 week and 2 weeks there was still release of voriconazole in the surrounding spacer, which was interesting. Thank you.
Excellent, Fabrice. There was one question, quick for you, silver-coated prostheses. Do you use them apart for revision surgery for infection or only for infected cases?
Well, I use them in oncology and revision surgery for infection, yes. But if I use tumor prosthesis for a revision, I will use a silver-coated tumor prosthesis.
Also for prevention of infection.
Yeah.
Prevention.
It's been shown for prophylaxis to be beneficial as well.
Yeah, as well, both cases. Excellent. Thank you for this case. I think, Lee, you have your last case, please.
Okay, because we're running out of time, we'll quickly run through this case. A few things that I think is important that we talk about, that, as we've said, antibiotics cannot save inadequate surgery. So surgery is as important, if not more important, than which antibiotics you choose. And what most people don't realize is that the 5-year survival for periprosthetic joint infection is actually worse than most common cancers. So unfortunately, about 40% of patients that have a PJI will die within the next 5 years, whether their infection is cured or not. And if we look at these most common causes of death rates for cancer in the UK, PJI would be the 5th worst cancer in the UK in terms of mortality. And we don't that the patient, the host is so poor, but they are. So my life is difficult. I showed you this algorithm that we used to use in Birmingham for when we do a treatment. But what about this poor lady who's very, very unwell, who's in hospital over Christmas and may not live to see another Christmas? Should we be doing a 2-stage revision for her? Because the point is that the survival, 10-year survival after a 2-stage revision is about 50%, and about 18% of patients will not get to their 2nd stage revision because they're too unwell or for other problems. And really, we're facing an unfair fight with infection. And so sometimes we have to think about getting a different approach, and sometimes we have to think about, with the sickest patients, that we should be more radical than we are with the fit patients. So this is our strategy now, where we do a DARE on the acute infections, obviously, but we'll do a radical single stage revision on the worst patients, because these are the patients that are unlikely to survive for several years. So why are we trying to get a few percent better outcome for them when they are not likely to survive for a very long time? What we need to do is give them the best chance of getting back up on their feet and out of hospital. So I want to present this case. It's an 81-year-old male with diabetes. He had a complex knee replacement previously. He presented to another hospital with a painful infected knee replacement with a CRP of 40 and systemically unwell with a high temperature. They undertook a attempt at a DARE and really did a washout, but they didn't have any of the polyethylene, so they just left it with some cement into it, and he was discharged on 2 weeks worth of antibiotics. This is not the appropriate treatment for an acute infection in an unwell man. I saw this gentleman 2 days before Christmas in 2018, and he presented with a streptococcal infection, with a relatively sensitive organism, but an abscess which was about to burst. And you can see that this gentleman isn't caring for himself properly, because he has no dressing on it, and he has the pus staining on his trousers. So this gentleman is a poor host. So we decided to do a single stage radical debridement for this gentleman, and we did a primary closure of his sinus. More worryingly, this area of osteolysis above the tip of the stem we thought was due to infection, but this actually turned out to be myeloma. So fortunately, we'd resected above this area because we thought the bone was osteomyelitic, but we'd actually resected his plasmacytoma as well. You can see that very rapidly his operation was done on Christmas Eve on the 25th, and by the time we got to the 13th of February, 21st of February, his CRP had normalized and remained normal thereafter. So his infection had been controlled by this single stage revision. This is his scar, and you can see that his sinus had healed up well, and this gentleman has very good function, but was only in hospital for about 10 to 12 days, and therefore we were able to get him back home very quickly. He presented again approximately a year later, and I thought that his knee was infected again, but actually it was his other knee. His CRP was 105. He's now got a permanent catheter, and he's already been started on antibiotics by another unit. He now has a very, very resistant organism to staph epis, resistant to no oral antibiotics apart from linezolid. And so I decided in my stupidity to do a 2-stage revision on him. We removed all of his implants, put a mobile spacer in. He had no sinus, and his infection came out to show Staphylococcus epidermidis, but the PCR also showed strep pneumoniae. And you can see here that we operated him on the 7th of November, and by the 11th of December, he was CRP was normalizing. But then, unfortunately, thereafter you can see that his CRP starts to rise again, and unfortunately, this gentleman died on the 8th of January. Now, perhaps the outcome would have been the same, but if I'd done a single stage revision on him on that time, he would have been out of hospital by then. And of course, there's a question about whether this was really COVID or whether it was a community hospital acquired chest infection. But my point is, it's sometimes in the sickest of patients, we're better off actually being more radical to get them out of hospital as quick as possible.
Excellent point, Lee. I like this single stage radical debridement. The better we are in surgical and antibiotic treatment, the less invasive we are in several surgeries. So I think it's a nice example of good treatment, and also importance of histopathological examination. Otherwise you would miss the tumor.
Yeah, yeah, absolutely.
Lee, there's one question. Do you advise the free vascular skin flap in revision surgery?
So the majority of times, pedicled flaps are quicker and easier. Very rarely, in less than 1% of our cases, we do free vascularized pedicled skin flaps. The trouble is that the donor vessels or recipient vessels, sorry, are often very poor because they're in the infected field, and therefore you need to come out of the infected field to do a free flap. And most plastic surgeons are very uncomfortable doing a free flap in the presence of infection. If we do it, then often what we do is we do our debridement first, then we do a vac, and when we're happy that the local infection is under control, then do a secondary flap reconstruction, maybe about 2 to 3 weeks later.
Thank you very much. Fabrice, maybe you can join us, and Lilith, you can put us on AV view, just to say goodbye to everybody. So you were great speakers again. I hope you will be able next time when we go even more in difficult and challenging situation. So thank you very much.
Thank you very much.
Thank you.
Take care.
Bye-bye.
Take care.
Now, Lilith, we can go to the wrap-up closure. So we are very happy to invite you on 16th of June to the third webinar, Tips, Tricks, Facts and Myths. So we will bring even more cases and have the same speakers. I would also like to mention that next week we are starting with a seminar on fracture-related infections on May 5th, and there are 4 modules of that. And in this stage, I would like to thank also all people supporting on organization and technical part, and of course, thank you, everybody, for staying with us. You can get all the presentations also in the download area if you want to look anything. So thank you and goodbye.